muscles and bones. So structure and function of the musculoskeletal system. Depending on when you looked, if you looked ahead at the slides at all, I did change some things yesterday afternoon. And by change, I mean just cut some stuff out. So depending on if you printed out the slides or you looked at it or you downloaded it or whatever, what you see this morning may be a little bit different and a little shorter than what you saw already. So if you see differences, that's why. Okay, so let's start chapter 36. Here are your most updated objectives, 1 through 6. All right, so when talking about the musculoskeletal system, we're going to start first talking about the skeletal system and talk about bones, and then we'll end the morning talking about muscles. So in terms of the skeletal system, obviously the most obvious functions of our skeletal system are the structural sort of foundation components of the skeletal system for our body. So forms the body, supports and protects our tissues, permits movement with the joints. But obviously, you know, a lot of the other things that maybe aren't as apparent or intuitive, certainly maybe are intuitive now since we've sort of finished our hematologic content. So we know now the bones are the site of the blood cell formation, and we talked a little bit about mineral storage at the bones as well. When talking about the site of blood cell formation, in adults, when talking about sort of bone marrow locations, the blood originates in a lot of the marrow of a certain bones. So a lot of marrow is found in the skull, actually, interestingly, in our vertebrae and ribs and sternum, and shoulders and pelvis. So a lot of our blood cell formation occurs in those bones, which is sort of interesting. It's not necessarily in the big, you know, honkin' mama long bones like the humerus and things like that. It's in these sort of smaller, more abnormal bones. And then again, so marrow of the skull, the vertebrae, the ribs and sternum, shoulders and pelvis are where a lot of the bones, our blood cell formation occurs. And then in terms of mineral storage, we're talking about, you know, the crucial role in mineral homeostasis. Obviously, the big mineral you think of when you think of bones is calcium. But what are the other two big minerals that sort of play a part or sort of have a relationship with bone as well? And magnesium. Good. Very good. Mag. Very good. Very, very good. Phosphorus and magnesium, and of course calcium. Okay. So let's begin talking about the skeletal system on a very sort of zoomed in level. So what we're going to do first in terms of the bone is start very zoomed in into the body. So very, very small micro level in terms of bone cells. And then as we start to sort of finish that conversation, we'll sort of gradually take steps back and then look more at sort of the bigger picture. So right now we're going to zoom in and look at the cellular component of the bone. We know that bone cells enable the bones to grow, to repair, to synthesize new tissue, and also resorb old tissue. And bones in order to do those functions, bone contains 3 different types of cells, right? We have the osteoblasts, the osteocytes, and osteoclasts. So let's spend a little bit of time here this morning talking about each one of those 3. So the first type of cell we're going to talk about are indeed the osteoblasts. These are, as you know, this is probably a review, your bone-forming cells, right? Osteoblasts are your bone-forming cells. You see some information here about them sort of I shouldn't even say pathophysiologically, physiologically here on the screen. What is their primary function? What is the osteoblastic primary function? To lay down new bone, right? To lay down and sort of mineralize and harden and strengthen the bone. Right, exactly. And when looking at sort of they respond to parathyroid hormone. It's interesting, right, that just like our blood cell formation responds to a specific hormone that's sort of, you know, under the umbrella of the endocrine system, as does bone as well. They respond to a hormone as well, specifically parathyroid hormone, because parathyroid hormone does a lot in terms of regulation of what? Calcium. Very good. Very good. And so they respond to parathyroid hormone. They also produce osteocalcin when stimulated by vitamin D. So that also shows you right there that vitamin D, the presence of adequate vitamin D, is very important in terms of bone health and laying down new bone from the osteoblasts. And sort of, by the way, osteocalcin is sort of this collagen sort of protein in bones and dentin that sort of give bones their sort of strength, but also their sort of ability to sort of withstand sort of weight bearing as well. So they sort of give a little so that you're not, every time you're sort of bearing some sort of weight or coming into contact with some sort of weight, that they're not breaking all the time. So that's what osteocalcin sort of does. And again, it's produced when stimulated by vitamin D. Also, osteoblasts synthesize something called osteoid. And what osteoid really is sort of this non-mineralized sort of bone matrix. Okay, so remember when we talked about at the beginning of last semester, when we talked about how cells in the body, making up a tissue, can't just be a bunch of cells laying there together, right? They kind of need to be sort of held together with some sort of glue or sort of inside some type of resin or matrix really to really hold cells together to create tissue, to create our kidneys, to create our liver, to create whatever. Bone is the same way. And that resin, that sort of matrix that holds all of those cells together is called osteoid, and it's secreted and made by these osteoblasts as well. So now, again, not only do osteoblasts lay down new cells, new bone, but they also create this matrix to hold all of those cells together, sort of in a resin, to create actual bone tissue. Yeah, so specialized, they really are sort of specialized fibroblasts that have both sort of an active and a resting state. And it's in their active state that they're secreting the osteoid, that they're synthesizing the osteoid. Okay? So that's osteoblasts in a nutshell for you. Then we have osteoclasts, and as you see here on the screen, and again, probably a review for you here, that they are truly the major resorptive cell of the bone. They resorb bone by literally secreting acid, hydrochloric acid, and some acid protein aces that actually help digest the collagen component of the bone, along with some actions of some cytokines also sort of help break down the bone. So why? It doesn't seem very intuitive that osteoclastic activity would be helpful, would be a good sort of physiological response. Why? Why do we want osteoclasts at certain times to actually resorb bone and break down bone? What's the importance of that? Anyone know? Anybody remember from their previous bone info? Yeah. Right. Huge, enormous bodies, right, of these big sort of unfunctional bones. Right, exactly. So osteoclasts, because of this sort of actually like hydrolytic enzymes and hydrochloric acid that actually carves out basically what they call cutting cones. They literally like sort of cut out cones in the bone itself to create spaces for the osteoblasts to now come in and lay down new bones. And she said it perfectly. If you didn't have this sort of balance between the cutting of old bone and the laying down of new bone, we would just build bone, build bone, build bone, build bone, and have these huge, enormous bones that are truly unfunctional and not helpful to sort of our body at all. So there is a time and a place, right, for osteoclastic activity, for their reabsorptive properties. Good. Again, they resorb through action of lysosomes and enzymes and actually acid that actually cuts down and breaks that bone. Good. Okay. And we'll talk a little bit more about sort of the importance of osteoclasts and how that actually happens in just a little bit. And then the last cell that I want to talk about are osteocytes. Again, they are transformed osteoblasts. They are the ones that are sort of matured osteoblasts that are surrounded in that osteoid, that hardened resin that was secreted by the osteoblast. And as these transformed osteoblasts that are surrounded in osteoid, they kind of get hardened as a result of the minerals in the bone that sort of entered the bone during calcification. So the way I think about it is osteocytes are sort of these transformed or more specialized or more mature osteoblasts that basically get stuck in that resin, in that osteoid that's being secreted by the osteoblast and help harden and mineralize that bone to sort of give it its weight-bearing properties and its ability to sort of, handle large loads. These osteocytes, again, synthesize the matrix molecules for bone calcification. So they really get caught in that resin and help harden that bone. That's truly the true sort of purpose and role of osteocytes. Again, think of osteoid as a resin, and these osteocytes get trapped in it to sort of create and strengthen, or sort of create a strong and strengthened bone. Okay, here's kind of a picture of some of these cells. A right here is osteoblast. So again, you can sort of see the cells right here. They're responsible for production of proteins that compose the osteoid. I'm going to skip to C here for a second. These are the osteoclasts. You can see here that you have sort of these cutouts, right? You actually have kind of these divots or these cones, sort of right here where I'm showing the arrow, where the osteoclasts are actively resorbing this mineralized tissue, the mineralized bone, and creating these holes for new osteoblasts to come in and lay down. And then B, I think, is a really good sort of visualization of these large osteocytes in here, and see how they're sort of trapped within this resin. See where my arrow is sort of circling? This resin that's kind of encapsulating and circling all of these osteocytes, and they're kind of trapped inside this resin. That's truly osteocytes trapped in that resin of that osteoid, creating that hard, nice, strong bone. So it's kind of a good visualization for you for some of these roles. All right. All right. So again, we zoomed way in, and we looked at bone cells. Now let's take one step out, sort of one step less zoomed, and talk about now when all of these cells are together, lumped together in this matrix, in this osteoid, they now create bone, right? The tissue, exactly. So let's take a little look now at the actual bone tissue. There's two types of bone tissue. You have compact or cortical bone, and then you have a different type of bone called spongy or cancellous bone. Let's talk a little bit about each one of these. Interestingly, both types of this bone tissue contain the same sort of structural elements, so they all kind of have the same parts to them, so to speak, with a few exceptions. But most of the time, compact and spongy bone have the same components, but they're organized. These components are organized differently in compact bone versus spongy or cancellous bone, thus giving them sort of a different texture, a different role, and basically a different look to this bone. So let's talk a little bit about the differences that lie between these two different types. So first of all, compact or cortical bone is a large percentage of our skeleton. It's 85% basically of the bone tissue in our body. Compact bone is extremely organized. It's very solid and extremely strong, right? So this is what truly gives bone sort of its tensile strength, is the compact cortical bone. And I sort of slip oftentimes and end up calling it the hard bone, right? Again, highly organized, solid, and extremely strong. It is made up of something called the Haversian system. And the Haversian system is truly the basic sort of structural unit of bone. And it consists of the following things here that you see on the screen. So for the purposes of kind of being able to sort of describe this, I'm going to actually move to the next slide and point out some of these things on this illustration to kind of make it come alive for you a little bit more. Now again, I apologize. These pictures are actually kind of small. If I blow it up any bigger, they get blurry and then you can see even less. So I apologize for the smallness of this, but I think we can make it work. Okay, so first thing, in terms of the bone tissue. So the Haversian system is basically made up of, the first thing is the Haversian canal, so this central canal. So if you would sort of cut a long bone in half, make it a cross section, and actually look at the cortical bone here, you would see that the cross section of cortical bone literally has rings, almost like the trunks of a tree, right? It literally has rings. In the middle of the ring is this central canal, or this Haversian canal, right? And as you move out from that Haversian canal, that central canal, you see something called the lamellae. The lamellae are the concentric circles. So if you want to think about it, it is truly in the comparison of the actual rings of the tree. So the lamellae are the rings of the tree. And then, so they basically are made up of concentric layers of the bone matrix, of those osteoid, matrix. Then in between each one of those rings, each one of those layers, you have something called the lacunae. The lacunae are those tiny spaces between the lamellae, okay? So you have the rings, and then you have spaces between the rings. And that's sort of what the component of those rings within the Haversian system are. You also then have osteocytes within them. So you see all of these sort of, within these rings, you actually have the osteocytes that sort of get hardened and trapped inside that resin, inside that matrix. And you have caniculi, which are sort of your even smaller canals, and you really can't even see those in this picture. But just know that they're within those sort of small canals, there's even smaller canals, and that's called the caniculi, the small little channels. Okay, so it's this tight, compact sort of nature of these rings, and then therefore the spaces between these rings that give cortical bone, hard bone as I call it, its strength, makes it hard, right? It's the way that this Haversian system is organized within cortical bone that makes it hard. Now, if we take a look at spongy bone, again, it's made up of the Haversian system as well. But I will tell you it's a little bit less complex. The Haversian system is a little bit less complex within spongy bone. It lacks some of the sort of organization of that Haversian system. And instead of having sort of rings on the tree, like we saw here in the cortical bone, you have something called trabeculae, okay? And what trabeculae is, and here's a really good sort of picture of that. See here, this picture here, C, is a good illustration of spongy bone. So this is a good illustration of a cross-section of cortical bone. This is a good cross-section of spongy bone. The lamellae is not in rings in spongy bone, but more in plates called the trabeculae. So you see how they kind of see like plates, kind of like a webbed-looking network of plates in spongy bone. That's called trabeculae. They branch and unite with one another to form sort of this irregular meshwork that really looks like a sponge, right? And so that's the difference really between the organization of cortical bone and spongy bone, is that they sort of contain the same parts, but they're organized a little bit differently. One to be more hard, and one to be sort of more absorptive and spongy. Okay. And as you see here, if you do a cross-section of like a long bone, like if the femur per se, you'll see that the cortical bone is located more on the outside of the bone, and the spongy bone is more on the inside. And that really is because of this spongy sort of meshwork sort of component of the spongy bone, it's what's located in here? Perfect, exactly. It's the bone marrow that really fills those nooks and crannies, fills those spaces of the trabeculae, of that sponge, so to speak. It's also in this spongy kind of bone where a lot of the capillaries pass through the marrow to nourish the osteocytes and actually nourish the bone. So hopefully it makes sense to you about why the spongy bone would be found more on the internal aspect of the bone next to the marrow, and the cortical bone would be more on the sort of outside protective aspect of the bone. Very good. I hope that sort of makes sense to you. And then if you go back here really quickly, after talking about compact and spongy bone, we'd have to talk just briefly about the periosteum, right? You know that the periosteum is sort of that protective covering on the outside of the bone. It's also exactly like it's like an enamel of bone. And you can honestly think of the periosteum as also as this sort of enamel on your teeth as well. Bones are covered with this sort of double-layered connective tissue that sort of lies on the outside of all bone and protects it. So just wanted to kind of mention that too before we sort of move off of this slide. All right. Any questions about the two different types of bone and sort of their organizational makeup and their system? Okay, good. Hope it sort of makes sense to you as to why they're located where they are. Okay. Okay, so now we're going to take even one more step out. We've talked about bone cells, then we've talked about the tissue of the bone, and now we're going to take a step out and look at the actual bones, the big sort of bones. We've got about 206 bones in our body. We can sort of classify them according to either the axial skeleton, which you see that sort of, which bones that sort of makes up, and the appendicular skeleton, so which bones kind of make up the appendicular skeleton. On this next slide, you see here a really good illustration of that. So the axial skeleton is in blue. Should make sort of sense to you. It's more of the sort of core. And the appendicular skeleton is in tan. So more of your limbs, and sort of, peripheral joints and things like that. Okay, so we also have, not only do we have two different types of bone tissue, but we also have two different, well, probably really even more than two different, several different types of actual bones, okay? So let's first talk about long bones. Imagine, just like as the name says, they are longer than they are wide. They consist of several different parts as well. So you have the diaphysis, which is that narrow tubular mid portion. So first of all, give me, again, kind of intuitive, but just make sure we're on the same page. Give me some long bones. Throw them out. Femur, humerus. Good, wonderful, good. Okay, so when looking at any of those bones, let's say femur, to be super straightforward and easy, right? When looking at that, you have that narrow tubular mid portion, that long sort of shaft part of the bone, right? Again, looking at this. Here I have sort of laid out for you the diaphysis, right? The long sort of mid shaft area of any long bone. In this diaphysis, in the middle, if you do a cross section, you have the yellow marrow. Now, what did I tell you when we were talking about the hematologic system regarding sort of the purpose of yellow marrow? Who remembers, who wants to sort of chime in? It's a storage site and almost like sort of a reserve site, right, for hematopoiesis. It's yellow because it really does consist of sort of fatty tissue. And it really only makes bone marrow. It only really assists makes blood cells. Only really assists the red bone marrow in hematopoiesis only during times of stress of the body. So illness, stress, things like pregnancy, things like that, right? So yellow marrow is sort of the reserve site to help out red bone marrow when needed. Okay, so they're truly the long part of the shaft of the bone is not really where most of our blood cells get made, right? It's just the yellow marrow in there. Then as you broaden out and you get to the ends, sort of both distal ends of the shaft, you have the metaphysis, which is truly sort of where the bone starts to broaden. You have the broader neck. Then as you sort of move even more farther out, you have the epiphysis, which is truly that broad end. And again, here is a picture of that. I didn't even really sort of, there's no label here for the metaphysis, but it's sort of here where it starts to sort of widen out. Here is the epiphysis, right? The epiphysis is that broad end. Now this is where you see a lot more of the spongy bone located. And if you see more spongy bone located there, what do you think you're also going to find there? The red bone marrow, right. So this is where a lot of the actual hematopoiesis, blood cell creation occurs, right? And you have more spongy bone and you've got more of the red marrow cavities in between all of that trabeculae. Good. Now, what's this right here? This cartilaginous plate that sort of divides the metaphysis from the epiphysis. What is that? The growth plate, right. And sort of, you see it here in this sort of illustration, which means, right, that what kind of bone are we looking at? A long bone of who? A child, right. You don't even see the epiphyseal plate anymore with an adult because that cartilaginous plate sort of gets filled in with bone and gets mineralized and hardened after the growth, obviously, of a child is finished. Good. Okay. In children, the epiphysis is separated from that metaphysis by that cartilaginous growth plate. It calcifies at puberty, and really, if you were doing an x-ray then after someone where that calcification has occurred, you don't even see that. So that's why I'm saying, like, we're looking at this, and you can certainly know that it's a child's bone because you can actually visualize that growth plate still. Question?
What did you say? Sorry,
no, it's okay.
What part did you say was the part where the baby goes?
The epiphyseal plate, yeah. That's where in that cartilage, it's made of cartilage when the child is young, right? And it's sort of malleable, so they can continue to fill in and mineralize. And that's where the growth, the actual new osteoblast growth, actually occurs in that plate. So that's truly where the bone continues to elongate and grow. It fills in that plate. It fills in that gap. And then when growth is done and the child is growing and has reached their maximum, height, that it calcifies, and then there's no more growth occurring there. So when we're talking about fractures in children, we're really concerned about a fracture in that area here where this, if it interrupts or does any sort of damage to that epiphyseal plate, because that's where the bone growth and the mineralization continues to sort of fill in and grow. If you've got a fracture in that area, what are we concerned about? growth, right? If they're of proper mineralization and osteoblastic activity in that area, if there's a fracture, and we're worried about improper growth now for the rest of the growth period for that child. Good. Very good. Does that make sense? Okay. So again, bones can be classified as long, flat, short, or irregular. We've just discussed long bone. Again, the shaft of a long bone is thick. It's rigid. It's basically made up of mostly compact bone. And the reason for that is that it's able to sort of tolerate bending forces. It's sort of tensile forces. And anyone know why, this is kind of just like a little FYI sort of trivia, but anyone know why at the end of long bones, the bones actually get broader at that epiphysis? What's the sort of the physics of that? Why do the long bones get longer and broader, or wider and broader at the ends of each one of those bones? Anyone know why? Yeah, support, and it allows basically more weight bearing to be sort of distributed over a wider, bigger area. So it basically increases the surface area, so to speak, of the weight bearing load of those bones. Good. Very good. Okay. Any questions about long bones? Okay. All right, so let's discuss the other bones as well. We have flat bones. Flat bones consist of basically the ribs and the scapula, okay? And really, flat bones have a totally different sort of structural makeup than our long bones. They really are consist of basically two plates of compact bone that are almost nearly sort of parallel to each other. And between that compact bone plates, you have this layer of sort of spongy bone in between. So you can see that their actual physical makeup is very different structurally than the long bones that we just talked about. Short bones are oftentimes referred to as cuboidal bones. These are our little bones that sort of slide and move easily over each other, like in our wrists and our ankles. They are made basically of mostly spongy bone, covered by a very thin layer of compact bone. So that being said, do you think it's easier, obviously, to break long bones or to break short cuboidal bones? Yeah, I mean, obviously, they're mostly spongy bone. They're mostly that more soft bone. So it's going to be a lot easier to break those small little bones in the wrists and the ankles than it is to, say, break your femur, right? And then you have some category of bones that really don't fit into any of those categories, so we call them irregular. And these are your vertebrae, your jaw, some facial bones, etc. And they really are various shapes that really include a lot of different sort of, organization of the thin and thick segments of sort of hard and spongy bone. But anyway, that's just kind of the introduction to the different types of bones and why you might see certain bones be more susceptible to fractures and to breaks than others, right? Because of actually what they're made of. Okay, so again, we really zoomed out now and talked about the big picture bones. Now let's kind of go back to this conversation regarding bone sort of breakdown and build up, this discussion regarding bone remodeling. Any questions before we move into sort of a new topic of actual bone remodeling and the importance of that? Yes? Okay. So bone remodeling is truly carried out by those clusters of bone cells termed basic multicellular units, okay? Basic multicellular units are basically the bone precursor cells that differentiate into osteoclasts and osteoblasts. So another way to sort of say that is that bone remodeling is carried out by the sort of balance and the relationship between osteoblastic activity and osteoclastic activity. To be clear, bone remodeling is sort of a recycling process, right? It's sort of the maintenance of bone integrity. So it's the process that repairs little microscopic wear and tear injuries to the bone. And it also is what maintains that sort of recycling process that we already talked about, right? If someone fractures, like has a big major fracture, or if someone has, say, like removal of some of the bone for, reasons of cancer or other types of injuries or things like that, is this the type of repair that occurs? What do you think? Does bone remodeling take care of the big sort of overhaul of bone that occurs with a major fracture or some other sort of major injury to the bone? No, right. That's a whole other process called bone repair, and we're going to talk about that. But I want to be clear. There's a difference between day in and day out sort of recycling and in sort of maintenance of the integrity of the bone, which is bone remodeling, versus the big overhaul of bone, which is bone repair. And we're going to talk about the difference of both of those. Okay, but in terms of bone remodeling, you have 3 phases, right? You've got 1, the activation of the remodeling cycle. So who do you think is in charge of that? The first step of bone remodeling is activation of the remodeling cycle. And you'll see here, it sort of is the cutting, it's the breaking down. So therefore, the first step in bone remodeling is actually osteoclastic activity, right? Because it really can't be osteoblasts forming new cells if there's no space, if there's no areas in which the new bone to come in and lay down, right? So you kind of have to cut away as the first step. So that's why osteoclasts are sort of the first step in the 3-phase process. So there's some sort of stimulus. Maybe it's hormones from the body. Maybe it's a drug coming from the outside that activates the formation of osteoclasts and then therefore the osteoclast activity. So then the actual reabsorption occurs. So you have osteoclasts forming those little cones, sort of digging out those cones in the bone, which I talked about, which gradually resorb the bone, leaving behind sort of this elongated cavity that's termed a resorptive cavity. It's now, after that process, after step 2, where there's now room. There's now holes. There's now little cones there waiting for the osteoblasts to come in and form new bone. So the laying down of new bone by the osteoblasts. They kind of come in and line the walls of those resorptive cavities. Now, this entire process takes a long time. So our bone sort of turns over and recycles in about a 3 to 6 month period, right? So let's take a look here at the visualization I have here. So here's A, where the osteoclasts come in and actually dig out a cavity, dig out a hole of the bone. Then B, you have the osteoblasts kind of coming in and forming and laying down on the lining of these cutting cones and sort of forming new bone. And so now you see in this last step, you see now not only have the osteoblasts come in and lay down new bone, but you also see now that it's hardening and it's creating that matrix, that osteoid in there and trapping some of these mature osteocytes in that resin to create the nice, strong sort of tensile strength of that new bone. So again, the remodeling process that you see here can really repair microscopic bone injuries, but not your big sort of gross fracture, surgical kind of resection of bone kind of thing. Those types of injuries, that bone repair, so again, not bone remodeling, but bone repair, actually occur in the same stages as like a soft tissue injury that we talked about last semester, right? So that type of bone repair happens the same way that sort of overall big sort of tissue gets repaired. That is different, to be clear, that is different than this day in, day out wear and tear bone remodeling, okay? Any questions about this process? Is that pretty clear? Yes. No, they actually kind of stay in that resin, and like I said, you can really think of them as more of like mature osteoblasts that just kind of get trapped in that resin, and they actually create the strength of the bone. So it's not that they die off, they stay in there and create the strength and the tensile force of the bone, or sort of be able to accept tensile force that the bone has. Good question. All right. Any other questions about this bone remodeling process? Okay. So again, why is it necessary? Well, first of all, this process, this 1, 2, 3 steps that we just talked about, allows the skeleton to respond to mechanical loading. What does that mean? What do I mean by that? In terms of the physiological process of bone remodeling and laying down of new bone, what does that mean? Has anyone heard, and this is true, has anyone heard that actually load-bearing exercises can actually strengthen bone? Right? We say that a lot when we talk about people who are sort of at risk for osteoporosis, that, load-bearing kind of exercise throughout your entire life actually kind of helps prevent or helps sort of decrease your chances of osteoporosis, because it's that load-bearing stimulus that actually creates this bone remodeling process and actually lays down new bone, thus strengthening bone. So it allows the skeleton to respond to mechanical loading. That's why, even though it's really rough on your knees, running is probably better for your bone strength than like swimming, right? Because you're actually bearing weight on those bones as opposed to not with swimming. It maintains quality control, so just that normal daily sort of wear and tear, repair and prevent of micro damage. And it also allows the skeleton to release growth factors and minerals like calcium and phosphorus, like you guys talked about already, to be stored in that bone matrix, that is stored in that bone matrix to the circulation. So it helps with sort of the mineralization balance as well. So again, these are some of the reasons why bone remodeling process is necessary. Okay, so that was bone remodeling. Now, we'll briefly talk about bone repair. Again, I mentioned already that bone repair, so what I mean by that is true overhaul and fixing of a bone that's been fractured or has had sort of, surgical resection, etc., happen in the same stages that any other tissue in our body sort of responds to. So, you can almost think of it as like, when we talked about sort of tissue repair, like a pressure ulcer, right? And how sort of the tissue sort of fills in from the bottom up and the sides in, right? Big major bone repair happens in the exact same way. So you first get that inflammation stage, right? Which is, again, if you want to sort of tie it back to the metaphor of tissue, think about it as sort of the big wound, right? You have the big sort of inflammatory wound in the skin. Same thing with the bone. The bone actually gets inflamed, actually creates a little bit of a hematoma there at that site of the fracture. And that's basically your first stage of bone repair, is inflammation and hematoma formation at that site of fracture, just like you would in a pressure ulcer or some other type of wound to the skin. Then the next two stages, the procallus and the callus formation, I personally think about it as sort of like the example of like a scab, right? It kind of scabs over, the active sort of hematoma, bleeding kind of stops, and you kind of get a callus there formed in that site of the fracture. So I kind of lump procallus and callus formation as kind of the scab in that metaphor. Then you get callus replacement. Now, when I say callus replacement, what replaces the callus? New bone, right? Exactly. So you get callus replacement of new bone thanks to the osteoblast coming into that site. And then the last stage is remodeling. And this really is making sure that the bone itself sort of looks pretty, right? So if I was looking at, let's say again for ease of conversation, I'm looking at a long bone fracture, okay? So let's say this is the femur. Okay? And we've got a nice, pretty fracture right here, right? All of these stages are going to occur. The hematoma, the inflammation, the hematoma is going to form at that site. You're going to get kind of a scabbed over kind of process there. And then you're going to get calcium or callus replacement of new bone in that site. If you were to actually do an x-ray of a newly sort of mineralized, newly sort of fixed fracture, it may honestly look a little bit like this. Why? Why would you see sort of some irregularity, maybe some sort of misshaped sort of appearance to the bone at a site where a fracture has just been fixed by this bone repair? Why would it literally look like that? Exactly, because of increased osteoblast activity at that site. And so it's not truly until you get this last final sort of remodeling stage where there is some osteoclasts that come in and sort of shave it off, make it look pretty, make it look like a normal shaft of a bone. So maybe right after a fracture repair, it would look like this. And then, because remodeling process kicks in, months down the road, you do another x-ray, whoopsie, and it would look like this again, right? We need remodeling to occur to kind of make it look pretty again, right? And sort of not have all of this increased osteoblast activity at that site causing an abnormality or a strange sort of function or strange sort of structure of the bone. So how fast does this bone repair happen? Well, the speed and the sort of the rate of this repair depends on a lot of things, obviously. The health of the person. Are there any sort of comorbidities? The type and the amount of bone tissue loss. So obviously a big, major, complex, compound bone fracture is going to heal differently than a hairline fracture, right? The presence of a lot of other diseases, growth and thyroid hormone things, et cetera, et cetera. The other big thing you really have to keep in mind is the amount of blood and oxygen supply available to that site. That's also something that you really need to sort of consider when thinking about the growth and the health, the process of bone repair. Yeah. We'll talk a little bit about that when we talk about alterations, and we talk a lot about fractures on Monday, but oftentimes that's because of the complexity of the bone fracture. Yeah. Oftentimes if it's super complex or unstable, they'll have to put a rod in to sort of stabilize that while it grows back. Yeah, we'll talk about that more on Monday. We're going to talk about fractures ad nauseum on Monday. But this is the physiology of the repair of those fractures that we'll talk about on Monday. All right. Interestingly, when talking about this process, spongy bone heals faster because of its characteristics. Now, why might that be? What characteristic does spongy bone have that would make it a better proponent for faster bone repair? Why do you think? Okay, it's not as complex, it's less organized, and I heard something else, that's good. It has great blood supply. It's right there next to the bone marrow. It has a lot of capillaries running in and out of it. So it has great blood supply. Its structure is a little less organized. And in that discussion of the structure being a little less organized, the way that I think about it is because it's less organized and it has more of that spongy sort of characteristic to it, it absorbs better. It absorbs nutrients. It absorbs the blood flow to it. And the way that I think about it is if you think about literally like a sponge, good old kitchen sponge, and a piece of cardboard, right? If you were to get both of those wet, the sponge wet and this piece of cardboard, which one is going to absorb better, faster, more efficiently? The sponge, right? And that's exactly how these two types of bone would respond as well. The spongy bone is going to absorb better, and because of that, it heals faster. Right. Very good. Very, very good thoughts. You're getting sort of the pathophysiology of it. Good. Okay. Any questions about that? Moving on. All right. So now when we're talking about bones, we have to talk a little bit about how they connect to each other, right? The joints. So obviously, they promote stability and mobility to that skeleton, to those bones. And the function really does depend on where it's located, right? So let's talk a little bit about the different sort of functions of bones. Obviously, for example, joints that stabilize the skeleton have a much simpler structure than those that move, right? I'm hoping that the sutures, the joints in my skull, are not near as mobile as my knee, right? That's what I mean. The function of it depends on where it is, and sort of the structure of it depends on where it is. Good. So there really are two ways to classify joints, and that is based on how they move or based on their structure. So and I will tell you honestly, it's more common to talk about joint classifications based on movement. So let's do that first, okay? So they're based on either movement or structure. And we're going to talk about classification based on movement first. The three types of classifications based on movement are synarthrosis, amphiarthrosis, and diarthrosis. So synarthrosis are those immovable joints. Like I just mentioned, the sutures in the plates of your skull, right? Pretty immovable, thank goodness, right? Maybe move a little bit in the pediatric sort of baby population until the bone fills into those fontanelles. But for the most part, pretty immovable. Amphiarthrosis are your sort of slightly movable joints. Given that definition, can anyone think of some examples of some amphiarthrotic joints? Mm-hmm. Good, almost like your pubic symphysis. Yep, good, especially it needs to move a little bit in pregnancy and things like that. Good. What other joints? Anyone can think of other joints that kind of fall into that category? How about like your vertebrae? We really don't want your vertebrae to be able to move like in a 90-degree angle, like your knee, right? But we certainly need a little bit of movement, right? And ribs too. They can also sort of expand and move a little bit with breaths, etc. And then diarthrotic joints are your freely movable joints, your knees, your elbows, your hips, etc. Your ball and socket are your hinge joints. Okay? So again, those are joints classified based on movement. Now the other way, as I mentioned, is based on structure. So the first type of that classification is fibrous joints. So this is the type of joint that sort of joins bone to bone. There really is no joint cavity associated with fibrous joints, and it really does allow for little, if any, movement at all. There's a couple of different sort of types of fibrous joints. The first is, again, like I was talking about before, the suture type of joint, and that's like the interlocking flat bones of the skull, right? The next example is syndesmosis. This is where two bony structures are just basically united and held together by a ligament. Can anyone think of an example of that? Two parallel bones just kind of joined together by a ligament. Like your radius and ulna. Perfect. Very good. And then gomphosis, this is a little bit interesting. Really the only example I can give you that I can think of for this is like your teeth. You don't really think about your teeth as joints, but it's really like your teeth have those little conical projections that fit down into sort of a socket. That is gomphosis. That is a type of a gomphotic, if you will, fibrous joint. Okay, how about cartilaginous? You've got either symphysis or synchondrosis. So symphysis, again, are where bones are united by just like a pad or a disc. And the purpose of that is to sort of act as a shock absorber. And again, it's already been mentioned under sort of the movement classification, but under structural classification, again, we're talking about like the pubis symphysis, right? Those two bones are sort of joined together by that shock absorbing pad, and it allows for a little bit of movement, okay? And then, so that's symphysis. Synchondrosis is where it connects two bones by sort of like a hyaline cartilage. Anyone think of any examples of that, where two bones are kind of really only connected by a layer of cartilage that allows for, again, some movement? Ribs and sternum, like where the ribs and the sternum sort of connect. They have to be able to move a little bit, right, to allow for expansion and contraction of the chest wall with breathing, etc. So that's a really good example of synchondrosis. And then your synovial joints are basically what you would think of in terms of your joints, right? You have your, your joints that are sort of uniaxial, biaxial, or multiaxial according to the shape of the bone ends and the type of movement that occurs at that joint. But usually, when you're talking about synovial joints, one of the bones is sort of stable, sort of acts as the axis, if you will, and serves for motion of another bone to sort of move around it. So a really great example I can give you for that is like the collarbone and the scapula, kind of being as sort of the axis and the sort of the stable bone that allows for the arm, the humerus, to sort of hinge off of and move around. That's a really good example of a synovial sort of relationship of a joint. So one bone is sort of fixed, while the other one sort of is able to move around it. Okay? Okay. And certainly the synovial joints are your most movable and most sort of complex joints in the body. Good. And then lastly, before we sort of end our conversation regarding joints, I want to just quickly mention the articular cartilage. We talked a little bit about that just a minute ago. But really what this is it's a layer of that hyaline cartilage that really does cover the end of each bone. And in fact, if you kind of flip back, I'm not going to do it on the screen, but if you kind of flip back to that picture I have of that long bone kind of dissected for you, you'll see at the top that articular cartilage at the top. This is either thick or thin, depending on which joint we're talking about, and really does fit nicely between, sort of acts as a padding between those two bones. It allows for weight and for shearing forces of that joint to sort of withstand it. The function really is to reduce friction in the joint and distribute the forces of weight bearing more sort of effectively and efficiently. This articular cartilage is what you hear about and sort of is what gets damaged when you hear like of pro athletes having like microfracture surgery where they got to go into the joint and kind of clean out sort of floating bodies and junk that kind of is floating around in people's joints. This is exactly what they're talking about. They're talking about sort of the breakdown and the breakup of some of that articular cartilage in joints that actually cause a lot of pain, especially in knees and things like that, where they have to go in and kind of clean out a joint. If you've ever heard of that, that's what they're cleaning out. Little bits of the articular cartilage that are sort of flaked off and broken off of that tip of the bone. So, it is a little bit different than the meniscus. This is actually almost like a thin little part of the cartilage of the bone itself, where the meniscus is more of like an actual body unto itself as the pad between those two. This is actually attached literally to the periosteum, to the bone. Yeah. But it can certainly, because of friction and repeated wear and tear, can certainly kind of start to break off. And when you hear of them talking about, floating bodies in synovial joints, it's this. That's the floating bodies inside those joints. Okay, now the next few slides are just some good sort of examples of some of the bones that we just talked about. Again, a lot of pictures here for you, just kind of as an example. Okay. All right, so now we've ended our conversation regarding bone, and we're going to spend the rest of the morning really talking about muscles. And we're going to do the exact same thing with the muscles that we did with the bone. We're going to zoom way in, and we're going to talk a little bit about the overall sort of, actually we're kind of going to go the opposite way that we did the bone. We're going to kind of start big and then zoom in. Okay, so skeletal muscles. Interestingly, as you see here, what they're made up of, 75% of water. Okay, now, just to kind of bring this kind of together with some things that we've already discussed this year already. If you remember way back to the fall when we talked about the geriatric population and how they are more, we talked more about sort of acid-base water electrolyte imbalances, we talked about the geriatric population being more at risk for dehydration. Now, given sort of this information that you see here on the screen, that skeletal muscles are made up of 75% of water, why might that be? Because of their decreased muscle mass, right? They are already more predisposed to dehydration because they literally have less water content in their body because they have less muscle content in their body. They have muscle wasting and muscle, wasting of muscle mass. So any kind of sort of alteration, an illness or any other sort of thing can really tip the scales very quickly and very dramatically to lead to dehydration in the geriatric population because of exactly this, because of the lack of skeletal muscle mass. Just kind of wanted to sort of mention that and bring some of these pieces together. Now, again, depending on which kind of muscle we're talking about, it can be super, super little, 2 centimeters long, to a big sort of 60 centimeter long muscle. And we really talk about muscles looking at kind of two different shapes or sort of forms of a muscle, fusiform and pinnate. Your fusiform muscles are your sort of elongated muscles that are sort of actually shaped like straps that run from sort of one end of a joint or one end of a bone to another. So again, given that definition, give me some examples. Bicep, tricep, quad, right? Exactly. Those are your fusiform muscles. Then on the other hand, you have your pinnate muscles. These are your more broad, flat, again, sometimes depending on where they're located, more sort of slightly sort of fan-shaped, sort of fan out, with fibers that run sort of obliquely to each other or obliquely to the muscle long axis as opposed to sort of the long fibers that run with these fusiform muscles. So, give me some examples. Pecs, glutes, good one. Deltoid, traps. Some of your oblique muscles in your abdomen. Good, very good. Say it again. Lats, yes, good, very good. All of those are great examples of that. And so again, not, just for sort of visualization, here is a lot of those that we were talking about. So here's some really good example of like I think someone said pecs for the pennate muscle, great example. Look at this fan shape, right? As opposed to, sort of the bicep here. I think you can sort of visualize the difference. Okay, so just make sure you have every one of these memorized for the exam. You're like, see ya, later, I gotta go. I gotta start studying. Just kidding. But again, just wanted to kind of have some visualization there for you. All right, guys. All right, so now I said we're going to kind of do the opposite that we did with bone. We're going to start out big and kind of start to zoom in now with the muscles. So let's start to zoom, okay? All right, guys, let's bring it back together. Let's zoom together. All right, so now we're going to kind of stop talking about the big sort of overall structure and form of the muscle, and now we're going to talk about what actually makes up the muscle, right? The whole muscle. What parts make up the whole muscle? So the first thing you have is the fascia. And again, for your reference, if you'd like to, as I talk about these contents on this slide, if you'd like to look at the next slide that sort of pulls apart each one of these parts of the muscles, please do if that helps you. In fact, I think I will. I think I'll stay on this slide and kind of talk about each section that's on the previous slide. So the fascia. As you see here, the fascia is really sort of this connective tissue framework that really lies on the outside of the muscle. It's sort of a connective sort of protectant, if you will, of the actual muscle tissue itself. Not only does it protect the muscle fibers within, it also attaches to the muscle and then attaches it to the bone. So really, as the fascia kind of tapers at the end of each muscle and connects it to the bone, it truly is what makes the tendon, right? Fascial tissue is what a tendon is. It's the fascia that sort of tapers and holds the muscle together and then creates the tendon that attaches it to the bone. It's also a structure for a network of nerve fibers and blood vessels that run to the muscle, and also some lymphatic channels that run in and out of the muscle as well. So like I said, works as a tendon, works as a protective mechanism, and really does sort of work, sort of acts as a structure for networks of nerve fibers, lymph channels running to and from that muscle. So then, as you take a step even farther in, then you really start to talk about the true muscle tissue, right? And the first sort of outermost layer of the muscle is the epimysium, right? This is the outermost layer, and as you see here on this previous screen, I say that the epimysium also sort of tapers at each end to help sort of form that tendon. But it's truly with the epimysium and that fascia that tendon is formed. So the tendon's kind of made up of both of those, not to confuse you. Okay. So here again is this big sort of epimysium sort of start of the muscle tissue. Then again, as you go sort of one step further into the muscle, you get the paramysium. Now again, as you sort of do a cross-section of this whole muscle up here, what does it sort of look like as you cut it in half? A pomegranate? Yeah, that's what I think it looks like. And so if you think about sort of all that little membrane that sort of divides all those little bundles inside the pomegranate, if you think about that in terms of the muscle, it's that membrane that sort of bundles all of those little different pockets that is the paramysium, right? So in this case of the pomegranate, it's that little membrane that divides all those sections up. It is, again, subdivides the muscle fibers into bundles of connective tissue and into each little sort of section of muscle called a fascicle. Okay? Now, if you take a look at the picture that I have on the screen, and you take a look at this sort of breakdown that I have on the board, you have the big overall muscle, and then as you get one step smaller than that, you have the fascicle. So within each muscle, you've got all these little segments of fascicles. So I just kind of like, if I would reach into just like the picture shows, if I would reach into the muscle and kind of pull out one of those little sections of the pomegranate, that would be your fascicle, okay? Then, if you would continue to reach into the fascicle and pull out from the fascicle one more little step, you get your actual muscle fiber, right? Your muscle cell. And we'll get to that in just a second. But I also want to sort of mention really quickly, within each fascicle, holding each one of these little muscle fibers, these muscle cells in place is the endomysium. So on this picture, it's this light little pink in between each one of these dark pink muscle fibers. Okay? All right. If you look on the picture here, so I'll do it with my pointer. If you look right here, the endomysium is this tissue right here that surrounds each muscle fiber within a fascicle. Does that make sense? Just look at the picture and you can kind of see it in the cross section. Okay. So then, as you sort of continue to pull out from this picture that we have here, you go from the muscle, you pull out a section, which is a fascicle. Out of that fascicle, you pull out one little strand, looks like almost like a licorice rope. Yeah, exactly. If you pull out one of those licorice ropes, that's a muscle fiber, as you see here. And then my diagram here on the board actually goes one step farther than this diagram on the PowerPoint and pulls out that within each muscle fiber, you've got lots of sarcomeres within that muscle cell, within that muscle fiber. Now, what is a sarcomere? What is it? What does it do in terms of its function in the muscle? What's found? Let me say what's found on the sarcomere. The actin and myosin filament. Right, exactly. So this, within the sarcomere, on each one of these Twizzler ropes, so to speak, right, is where you find your actin and myosin that actually slide over and across each other. So you actually create the muscle contraction. Right? So again, so I have that here. Within the sarcomere, you have your actin and myosin that interact for actual muscle coupling and muscle contraction. So again, my diagram on the screen goes one step further. My diagram on the board goes one step further than this picture on the screen. Okay? Now, this that I'm talking about right here is purely structural. Right? We haven't even discussed really the function and sort of the motor aspect of what these muscles do. I'm literally just talking about the actual sort of structure, organizational component of skeletal muscle. Okay? So to be clear, this is purely structural. Was there a question? Nope, just stretching. Okay. All right. So any questions regarding structure before we move on to sort of more conversation and eventually get to function? Any questions about that? Pretty straightforward for you? Okay. So, when we start to talk about muscle, we get away from the structure conversation and we start to talk about more of the function. When we're talking about skeletal muscle, which is what we're talking about today, right? Musculoskeletal system, we're talking about our voluntary muscle. So, we know that it's controlled by the nervous system. We talked about that already when we talked about the neurologic system. We know that skeletal muscle is striated. It has a striped pattern under the microscope. Don't worry about extrafusal, just cross that off. And what we need to discuss when we're talking about skeletal muscle is, okay, how does it actually function? And the way that it functions is through what we call a motor unit. Okay? Now, the motor unit consists of three things. It contains an anterior horn cell. It contains that cell's axon. And it contains the actual muscle fibers in which that axon connects to. So let's talk more specifically about this, okay? So we know that motor information in the spinal cord comes down from our nervous talk a couple weeks ago, comes down on which side of the spinal cord? The anterior side, right? Right. So that's why we say that those cells, those initial sort of nerve cells, are located on the anterior side of the spinal cord, and so they're anterior horn cells, right? Then, so those cells, the cell bodies, stay in the spinal cord, and its axon, which is literally part of those lower motor neurons that we talked about in the neurologic component, is what actually leaves the spinal cord and reaches out to the actual peripheral muscles, right? And again, if you look at this picture, this is a great picture of it. Here's the cell bodies here in the anterior horn. You see the actual neurons branching out of the spinal cord and connecting out into the periphery to the actual muscle fibers, right? And where those neurons connect to each one of those muscle fibers is called, lo and behold, the neuromuscular junction, right? So it's these three things that compose the motor unit. The cell in the anterior horn, the neuron that reaches out to the muscle fibers, and then the actual junction where the muscle fibers and the nerve actually meet. That is a motor unit. Okay? Now let's go back to the previous slide. So each one of these motor units behave as a single entity, okay, and contract as a whole when electrical impulse is received, right? When it actually tells, when there's actually that electrical impulse that goes down the neuron and talks to that muscle. Now listen to this. This is kind of interesting. The whole muscle may be controlled by several motor nerve axons, right? So obviously one isn't going to affect the whole quadricep, so to speak, right? So many motor units are needed for an actual efficient muscle contraction. All of these sort of motor units branch to innervate, or I should say all of these sort of neurons branch to innervate many motor units within the muscle. And then depending on which muscle that you're talking about, really sort of depends on the muscle, how many motor units run to that muscle to create an effective contraction. So for example, in the calf, for example, one motor axon innervates 2,000 muscle fibers. So again, if you're looking at this picture, see how one motor neuron branches out? It would then, at the end here, at these neuromuscular junctions, branch out to affect and to basically grab 2,000 muscle fibers. And that's just in the calf. Okay? So that gives you an example of the way these motor units sort of run from the spinal cord out to actually control the muscles itself. Okay. Now, then why, if we're talking about motor and the actual function and contraction of muscles, do I talk about sensory receptors? Why am I talking about the sensory side of things if we're talking about muscle and motor component of things? What's the importance of sensory in this relationship? That's what tells us what to do, right? It's the sensory information that runs up to the brain that then runs the motor information back down the spinal cord to go out. So it's those mechanical sort of receptors that respond to muscle stretching, to muscle positioning. It's what allows for us to sort of have proper balance and proper posture, because it's those mechanical receptors in our sensory that then tell our brain what to do with our actual muscles to keep us upright, to keep our balance, to contract that quad muscle, et cetera, et cetera. Okay? So again, you can't talk about the motor unit and the sort of functional part of the muscle without talking about the sensory part of it that goes with it. Okay, and there's a picture for you. Any questions about that? All right. So, when talking more about function, we really can't discuss function without specifically talking about myofibrils, so the muscle fibers. They're the functional subunit, so to speak. So the speed with which a muscle fiber lengthens and shortens, so contracts and relaxes during some sort of movement, indirectly influences the strength and the function of that muscle and of that muscle contraction. And within our body, we have two different types of muscle fibers. We've got type 2 fibers and type 1 fibers. Now, type 2 fibers are innervated by relatively sort of large type 2 alpha motor neurons that have very fast conduction. So when I'm talking about type 2 fibers that have very fast type of conduction to those fibers, to that muscle fiber, what kind of contraction or what kind of muscle activity do you think would be an example of a type 2 sort of muscle contraction? What do you think? Reflexes, sort of your fast twitch kind of movements. So a really good example is like your eye blink. If something's coming at your eye or someone's kind of taking a swing at you, automatically, your eye blinks, right? Now, I will tell you, because they're so fast and it's such a fast kind of conduction, such a short-term kind of conduction, it relies basically on very short-term anaerobic sort of muscle activity. It doesn't really need a lot of oxygen, obviously, for these very fast kind of muscle conduction or muscle contractions, right? So it relies on short-term anaerobic sort of glycolytic system for rapid energy transfer, okay? As opposed to red muscle, or sort of your type 1 fibers, these are sort of your bigger sort of postural kind of contractions. This would be an example of like your postural muscles, so the kind of muscles that allow me to stand up here upright and talk and stand for 2 hours, right? So given that, so my muscles in my legs are contracting, my quads contracting to keep me upright, my core muscles are keeping me contracted and upright. So given that it's long-term sort of postural contraction, what kind of sort of metabolic activity do you think those kind of muscles need? Or more long-term, long kind of contraction. What do you think they need? They need aerobic. metabolic activity. They need oxygen, right? And because of that, because they're aerobic oxidative metabolism, those muscles are very resistant to fatigue, right? I can stand up here for 2 hours, and I'm, feeling pretty good. I'm not too fatigued, right? As opposed to, can you imagine if I stood up here and tried to blink my eye for 2 hours? My eye would fatigue. That muscle, that fast twitch muscle in my eye would fatigue after 2 hours. Not so with your quads, muscles, and things like that, right? So again, to be clear, type 1 muscle fibers need aerobic oxidative metabolic processes because they're very resistant to fatigue. Type 2 fibers, your fast twitch, sort of reflexive muscle contraction, does not need oxygen. It can happen very short term anaerobically, to be clear. Okay? Now, to finish up here this morning, I want to briefly discuss this conversation when continuing our conversation on muscle function and talk a little bit about those sarcomeres. You've already told me, right, that what's located on the sarcomere is your thin filaments, your actin, and your thick filaments, your myosin. And the ability for those filaments, those bands, to sort of couple, connect to each other, and pull each other in to cause a contraction, right? Now, does this just happen? Does myosin just attach to actin willy-nilly any old time at once? No. What's needed? What's needed for proper sarcomere function and for proper actin and myosin coupling? What do you need to have happen? I'm sorry? Great. So first you need an action potential. And actually, if you want to go to the next slide, you can kind of look at this slide and the next slide in conjunction with, not that slide, this slide. You need an action potential, right? So you need the spread of that action potential from the nerve terminal down to that neuromuscular junction, from where that nerve actually hits and touches and connects to the muscle fibers themselves. And then once that action potential occurs, what happens next? Say it again. Well, okay, so before that, you need rapid depolarization of that membrane to initiate electrical impulse in the muscle fiber to create that action potential. Now, so that's kind of number one, the excitation of that whole sort of relationship and of that environment. Now, 2, the next step in muscle contraction is the coupling. So now, tell me now what happens in coupling after the depolarization of that muscle fiber. Tell me what happens now. Yeah, so calcium gets released after this sort of depolarization. And why is calcium so crucial in actin and myosin coupling and them pulling together? Yeah. Right, exactly. So basically what it does is it binds to tropomyosin, which then moves troponin away from the binding sites, because troponin basically acts like a lock to sort of lock myosin and actin from coupling and joining together. So when you've got calcium bind to the tropomyosin, it basically moves away. How much time do I have? Okay, good, I'll draw a picture. So here is a really sort of immature drawing of this, okay? So here's your myosin filament with your little head. It looks like kind of like a golf club, right? And here, let's say, your actin kind of looks like a little string of pearls, so to speak, right? Okay. Here, this binding site right here is covered, is blocked by troponin, okay? And at this other site up here, let's say this site up here on the actin is tropomyosin. When tropomyosin gets into contact with calcium, when calcium binds here or sort of connects to this tropomyosin site, it sends a signal to troponin to move out of the way and allow for the actin and the myosin to connect. When they connect, they couple and they pull each other in and allow for muscle contraction. So, why? With this coupling, so triggers release of calcium ions, exposing the binding sites on the actin molecule, and then actin binds with myosin. Why? Why is it important that troponin sits here and blocks actin and myosin from coupling? Right, or else we'd be like in rigor mortis all the time, right? With constant contraction of every muscle at every second of the day, right? So thank God that troponin is there to block that from happening. And it's only with this action potential that then when we need our muscles to contract and the action potential has been released down that neuron to the neuromuscular junction, that it then says, okay, for a little bit, we need to have some muscle contraction going on here to run or to breathe or to move our rib cage so they can breathe, whatever it may be, thank God. That then tells us, move the troponin away and bind, but don't bind forever, right? So you get contraction, myosin heads attached to the exposed actin binding site, and you get coupling. You get the sliding of those filaments over each other to connect and to contract. But luckily, it doesn't stay that way, right? You have number 4. You've got relaxation eventually too. And basically what happens then is that the calcium ions that were there on the tropomyosin get actively transported back into the other part of the muscle cell, the sarcoplasmic reticulum, removing that interaction from the troponin, and all of a sudden, the troponin moves back to that site, and the actin and myosin have to let go of each other, right? So those are the 4 steps in muscle contraction, and basically those are the 4 steps of why our muscles contract in conjunction with that neurologic sort of instructions, if you will. Okay? So that's why calcium is so important, right, in terms of muscle health. If you had too much calcium in the blood, circulating in the blood, therefore too much calcium ending up in the muscles and too much calcium ending up on this tropomyosin site, and it's constantly sitting on that tropomyosin site, what are you going to see in terms of muscle activity? Say it again? Right. Exactly. And then vice versa, right? So calcium, and we'll talk more about this because we're going to talk about calcium a lot more when we talk about endocrine and things like that. But I just want you to be able to understand steps 1 through 4 here of muscle contraction. And just kind of for your reference, I kind of have a picture here for you, but really what I want you to understand is that with each one of these sort of, licorice ropes here is a myofibril, and it's on these myofibrils that you kind of see here is where these actin and myosin sort of strands would lie, okay, right in here. All right. More than you ever wanted to know about bones and muscle. But again, it lays a really good groundwork for us when we start to talk about alterations on Monday. All right? Thanks, guys. Have a great weekend. Yeah, the rest of the stuff we will not cover. Yeah, like I said, I just did it yesterday afternoon. So if you did it beforehand, it's going to be a little bit different than what we did this morning.